We shall now move on to the next scientific session.
I would like to call upon stage the presenter for the next session, Dr. Haresh KP. Dr. Haresh KP, Professor, Department of Radiation Oncology, AIIMS, New Delhi. He has more than 50 publications to his credit and his area of interest is urogenital cancers. Now, we hand over the sessions to our chairpersons.
Thank you. So let me invite Dr. Haresh KP, and he has to speak on interstitial brachytherapy in prostate. Over to Dr. Haresh, please.
Good morning, respected chairpersons, my teachers, Dr. Rath, and my friends. First of all, let me thank Dr. Saroj, Dr. Parida for inviting me to this, this conference. I'll be initially stressing on little aspects of the basics so that the postgraduate students will benefit from for selecting which right patient is fit for brachytherapy prostate cancer. And during my talk, I will also stress on the practical aspects of how to do the prostate brachytherapy, as it is done very less in this country. And a little bit of literature and a small video of 2-3 minutes. The TNM staging is very important when we talk about prostate cancer. The T1 stage, which is there is no the gland is clinically normal, but there is positive less than 5% in T1A, T1-2, T1B, more than 5% of the tissue is positive when the prostate is removed for some other reason. And T1C, the biopsy is positive when the gland is normal on examination and imaging. And T2 is confined to the prostate. T2A, less than 1/2 of one lobe is involved. T2B, more than 1/2 of one lobe. And T2C, more than both lobes are involved. And T3A, periprostatic involvement. And T3B, seminal vesicle involvement. And Gleason's, which is the grade of the cancer in the prostate, which shows the aggressiveness of the tumor. We have grade group 1, which is 3 plus 3, 6. Grade group 2, 3 plus 4, 7. Grade group 3, 4 plus 3, 7. And grade group 4, total Gleason score of 8, and grade group 5, and a total of 9 to 10. And when we talk about risk stratification, the Gleason score, the PSA, and T stage is very important. All the three plays a role to find out what is the risk group that you are dealing with. Main important is the low risk, intermediate risk, and high risk. In the low risk, we should be T1 to T2A, and the Gleason score of less than 6 or 6, and PSA of 10. All the three should be present in low risk group. Intermediate risk group, it is T2B to T2C, and the Gleason of 7 and PSA of 10 to 20. And the high risk, T3A onwards, and Gleason of 8 or more, and PSA of more than 20. Any of these can be a qualifying feature for this group. And broadly about the management of prostate cancer, for low risk, it can be either active surveillance or radical radiotherapy or radical surgery. In this group, we can go ahead with brachytherapy alone as a mode of treatment. In the intermediate risk group, short course of hormone therapy followed by radical radiotherapy, and it can also be treated by surgery also. And in high risk, it is a long course hormone therapy followed by radical radiotherapy, and surgery also can be considered. In intermediate and high risk group, there is an important role of brachytherapy boost for local control in prostate cancers. And we all know that higher the dose, the better the results in prostate cancer. There is a higher biochemical control rate when we increase the dose in prostate cancer. A lot of studies address this issue. And brachytherapy is the best way of dose escalation. You can see the dose that we can achieve around the needles, 150, 200%, that cannot be achieved by any form of radiation as of now. And at the same time, what is more important is when you do brachytherapy, the dose to the urethra is kept low. Not only to the urethra, the surrounding structure like the bladder and rectum also are kept low when you are escalating the dose to the prostate. Radiological also it suits very well because you know that prostate has got a very low alpha by beta ratio of 1.2 to 1.5. That means they do better respond to higher dose per fraction. And also the mechanism of cell kill in higher dose per fraction is also a little different compared to the conventional mechanisms, more of damage by lipid membrane phosphorylation, necrosis, immune-mediated cell kill, and so on. You can see one of the earliest reports of brachytherapy in carcinoma of prostate and bladder. It dates back to 1917 in JAMA. This report. And when we think of brachy for the prostate, there are two types. One is the seed brachytherapy, which is LDR, and the high dose rate brachytherapy. Seeds, you know, the iodine 125, palladium 108, and then cesium. These are all routinely done, but in India, very few centers do this. And the HDR is done by iridium 192. And the seed procedure is a single outpatient procedure. The HDR is usually repeated maybe weekly or 2 weekly, 3 weekly and on. And there is little risk of radiation exposure to the healthcare workers when you go for seed implant, but there is no risk in HDR. The another advantage of HDR is that once you can play with the dose distribution. In the seeds, once the seeds are inserted, there is no luxury of modifying the distribution. And the side effects profile also, when you go for seeds, the side effects are little more and little prolonged. But in the HDR procedure, the side effects are little less. And there is also a favorable profile of inverse square law with seed implant. But still, the dosimetric advantage with the HDR, where you are able to sculpt the dose to the tumor, is not there with the seeds. What is the ideal patient for brachytherapy? There are two things. One is treating the whole thing by brachytherapy alone, and other is a boost. For monotherapy, the indicated patients are the low risk disease and favorable intermediate risk disease. As a boost, it is unfavorable intermediate risk disease and the higher disease. They are the patients who will be selected for boost brachytherapy. What are the contraindications for brachytherapy? Pre-existing rectal fistulas, patient who was unfit for anesthesia, spinal epidural anesthesia, and there's no proof of malignancy, or we need a rectum because to do the truss-based implant, that's more important. And there are other relative contraindications, the previous radiation for pelvis for other reasons, prior rectal surgeries, inflammatory bowel disease, and larger volume of prostate cancer more than 60 cc. This is a relative contraindication, and the flow is not good, and there is a significant post-void residue, and large median lobe, and IPS score more than 20, and pubic arch interference, that's also a relative contraindication, and large and unhealed TURP defects. You can see that when you go for monotherapy, there are different dose schedules that are followed. The overall, you can see that the BED that you achieve is more than 250 gray. And for the combination where initially you give external beam radiotherapy followed by brachytherapy boost, different dose regimens. When you follow a reasonable dose regimen above 9.5 into 2 and down onwards, you can see that the overall BED that you achieve is more than 250 gray. And you can see the dose regimens that are recommended in NCCN. For the monotherapy, you can see 13.5 gray into 2 implants, and for the other regimen is 9.5 gray, two treatment into 2 implants. And for the boost, you can see that 15 gray single session implant or 10.75 gray in two session implants. Whether you do brachy before external beam or after external beam or during external beam, it doesn't matter. There are advantages and disadvantages doing either before or after also. Whenever seeds are done, it's usually done after finishing external beam radiotherapy. When HDR is done, you can even do before. Brachytherapy can act as a radiosensitizing sort of thing for external beam radiotherapy if it is done before, because there are some transcriptional changes that are happening when high dose brachytherapy. Some practical aspects. This is for the boost thing. Initially, after 45 to 50 gray of external beam radiotherapy pelvis. Initially, when we started, we gave 9.5 into two fractions with a single implant. Once we do the procedure, the patient will get first fraction on the same day and the second fraction on the next day morning. The whole procedure was ultrasound guided. Before taking the patient for the procedure, we should ensure that the patient is not on aspirin, clopidogrel or any blood thinners. We get to see the CB's complete blood count and the biochemistry. And we usually start a dose of antibiotic on the day of the procedure, and the bowel preparation as we do for any colonoscopy procedures with PEGLEC, and part preparation. And it's usually done under combined spinal epidural anesthesia. High lithotomy is very important for prostate, because unlike in cervix, high lithotomy is very important because there is an issue of pubic arch interference that happens, and you have to tilt the pelvis so that the needle doesn't hit the pubic bone. And after cleaning and draping, catheterization with a 3-way Foley's is very important. Usually 16 or 18 French catheter is usually done. And another important thing is we have to keep the Foley's closed. We should not be draining into the uro bag. And another very important thing that we need to remember is that the Foley's has to be high up in the bladder and not down, or else your needles are going to puncture the balloon and you will not be able to complete the procedure. So, and the scrotum is strapped up, and then the template is prepared, and the dress also has to be ready. And one important thing that you should remember is that before starting the procedure, you need to clean the rectum of the stools. We usually use an infant feeding catheter or a suction catheter and inject 50 ml of saline into the rectum and ensure that there is no mucus or stool specks in the rectum. It's important because if there is even a small speck of stool in the rectum, your ultrasound image is going to be completely black out, and you will not be able to perform a good implant. This is very important before you start. This is what I was telling, that the Foley's has to be high up so that you don't puncture the balloon. And ultrasound guidance is very important. This is the latest ultrasound that we're having in our department. BK 5000 is a state-of-the-art machine for any brachy procedure, and these images are like any MRI image quality. So it's very important. And this is one of the steps that we do routinely that may not be required required. Maybe for the beginners, you need to do. You have to initially under ultrasound guidance, you insert one or two LP needles and see the position of the prostate so that you can draw on the perineum where to place the template. And the needles are inserted one by one under ultrasound guidance. And whenever you insert the needles, some principles you have to follow. Usually around 15 needles, we do 15 needles, maybe 14 to 18 needles are done. And the needles are usually 7 to 10 mm apart. These are guided by the holes in the template. And whenever you start from anterior and downwards, because once you start, if you start from down, then the artifacts of these needles will create difficulty for you to insert the rest of the needles. You may not be able to see the remaining part of the prostate. So always start from anterior and downwards. And there are 3 planes that we see. That is the base plane, up, then reference plane, and apex. Always try to target the reference plane, which is the maximum dimension of the prostate. Once you do the implant properly in the reference plane, you will definitely cover the remaining of the prostate. And always it is a peripheral loading that is important. You do the peripheral loading, and most of the needles are in the periphery. And then for the needles which are near the urethra, it should be at least 5 mm away from the urethra, or else you will struggle to achieve the minimum dose for the urethra, maximum dose for the urethra during your planning process. And the posterior needles should also be inside the prostate and away from the rectum. And all the needles will be puncturing the bladder, and the needles will be 1 centimeter inside the bladder. If you are away from the bladder, you may not cover the prostate properly. You don't need to fear about the hematuria, but that can be managed. And once the insertion is done, patient is shifted to CT scan for CT imaging. And then the treatment planning is done. Initial needles are reconstructed, the OIR and the PTVs are drawn. And generally, our PTV is the prostate plus and the disease extension plus 3 mm. That is our target. And the margins are not much added posteriorly and superiorly. And there are a lot of plan evaluation parameters, but I will stress on the parameters that we follow in the coming slides. And those planning and the reconstruction and the patient is taken for treatment. Whenever we do this procedure for any brachytherapy procedure, in interstitial brachytherapy procedure, there is an issue of when we reposition the patient from the lithotomy position down, the needles do move a little bit, maybe up to 1 centimeter. And there is an issue with shifting of the patient, multiple shifting of the patient from the table to the treatment room. So these lead to displacement of the needles, and lot of uncertainties can be possible. And this can lead to poor coverage of the tumor and excess dose to the OIR and trauma to the tissues, and even it can increase the hematuria also. There are some studies which have shown that when they did multiple sessions of treatment on single implant, the needle displacement is, you can see that even 1 millimeter, 2 millimeter displacements are seen in between the treatments. So another technique is real-time ultrasound guidance, guided constant of prostate brachytherapy procedure or SWIFT, which we started after 2015, and Dr. Rath was very visionary to have this set up in our department. And this is a real-time ultrasound guided procedure, HDR procedure, and this is a setup that you can see. This is a class 1 robotic system. This procedure is also under ultrasound guidance. The only thing is that there is extra TPS that is there, and the whole procedure insertion and treatment planning and delivery is done in the operating room itself. And the planning is also ultrasound based, not CT based in this procedure. And the HDR room has to be converted into the operating room, and there should be a facility for remote control from outside. One extra step that we do in this procedure is the prostate anchor needles, where we put the anchor needles into the prostate and hook the prostate to the base plate, so that the prostate doesn't move related to the base plate. And 3D ultrasound images are required, and there's a pre-planning that we do, and so that we see the dose distribution of the prostate and the dose to the OIRs, and ensure that we are not crossing the OIR limits. And we have pre-designed slots for inserting the needles. And once the plan is ready, we go ahead with insertion according to the pre-plan, and then we do planning again. And once everything is finalized, we connect the HDR machine to the patient, and then to the needles, and then deliver the treatment and remove the needles in the same position. In the lithotomy position itself, we will complete the whole treatment. But the issue is that it will take 2 to 3 hours for the whole procedure. And the dose constraints that we follow in our institute, for the boost, it is 10.5 gray, 9.5 to 10.5, that's what we follow routinely, and two separate implants. And for the monotherapy, 11.5 into 3 implants. The dosimetry parameters for the prostate, D90 always should be more than 100%, V100 is more than 90%, V150 less than 35%. And the urethral dose also, we have constraints for that. The D10 and D.1 cc, less than 115 and 120%. And the bladder rectum, the D10 cc, less than 75%, and D.1 cc, less than 80%. It's very easy to follow these very easy constraints. And if they are not achieved, we always try to optimize it. And just showing the dosimetry. And post-implant care is also very important. And we should not be removing the whole template and needles together. We should remove one by one only, or else it will cause more of trauma. And after removing the needle, we have to apply continuous pressure over the perineum at least for 5 minutes, so that bleeding is stopped. And the Foley's has to be pulled down so that it also acts as a tamponade for controlling the bleeding. And we start the irrigation immediately with saline. And this irrigation is continued till the hematuria subside. And the Foley's is removed in the next day. There's some literature on HDR monotherapy. I'm not going to the detail. And you can see that 5-year failure-free survival biochemical failure rates are pretty good, more than 85%, and oral survival more than 95%, and so on. And this literature for boost brachytherapy in prostate cancer, and the results are really good. There are 3 randomized controlled trials for boost brachytherapy for high-risk prostate cancer. You can Satya trial, the Peter Hoskin study, and the Ascend Artist trial. All these studies have shown better biochemical control by adding brachytherapy boost in prostate cancer. They were all statistically significant. And this is the detail about the Peter Hoskin study. And the one arm it was 55 gray in 20 fractions, the other arm was 35.75 gray in 13 fractions external beam, followed by a boost of 8.5 into 2. I admit that in both the arms the dose was a little inferior, but still you can see the results were better with brachy boost and significantly better. And the acute toxicity that you can expect with the brachytherapy is dysuria of 6%, incontinence of 3%, urinary retention 11%, and frequency, diarrhea, rectal pain and rectal bleeding, and hematuria of 11%. But this hematuria can be controlled. The late toxicity is the most important is bulbourethral strictures, 8% with monotherapy and 30% with combination therapy. And the grade 3 and grade 3 plus GU and GI toxicities are acceptable. And one of our study, we randomized patients after pelvic RT of 45 grade 25 fractions to either external beam boost or brachytherapy boost. And this dosimetry comparison showed that you are able to achieve a better, higher dose to higher BD to the prostate, and at the same time lesser dose to the OARs, statistically significant difference. And the toxicities that we achieved in the study, there was numerically better, inferior toxicity, less toxicities in the brachy arm, though the difference was not statistically significant. And publications. And usually the patients are followed up 6 to 12 monthly with PSA. DR is not routinely done much, and quality of life assessment like the bladder symptoms, rectal symptoms, and sexual symptoms. And one important thing is the PSA bounds. These are all transient rises in PSA, which are not because of the disease per se. You've seen that it's less than 2. That is why the Phoenix definition of 2 plus NADR. So that usually it's seen till 30 months, not after 36 months. And just about another indication for brachytherapy, salvage brachytherapy. If the patient present with the recurrence only in the prostate bed with a PSA doubling time of 1 to 2 years, more than 1 to 2 years, and the PSA is less than 10, and Gleason not a very high Gleason. And results of salvage brachytherapy, and just show the video. Yes, the high lithotomy is very important because to avoid the pubic arch interference. And these are the things that we inquire for the prostate brachytherapy, the template, and other things. And this positioning the Foley's tube high up is very important. This should not be ignored. And the truss probe, we usually use a stepper with a floor mounted stepper. There is another stepper is couch mounted. We use a floor mounted stepper so that nobody needs to hold the truss probe. It's very easy so that the images are very stable. And initially we are obtaining the ultrasound images for the BK ultrasound image. You can see the clarity of the images that you can see, the different planes, the base plane, the reference plane, and the apex. This is a bladder you can see. And the template is fixed to the perineum by suturing it to the, and then the needles are inserted one by one into the holes, starting from anteriorly and down. You can see the position of the needles. You should cover the prostate very well. And the procedure is advancing, and all the needles are inserted. And the position of the needle should be at least 1 centimeter inside the bladder, or else you will not be able to achieve a good coverage for the tumor. And the completed template, and you can see the needles in the prostate. and the patient is taken for a CT simulation. Show the CT images. And the images are pushed to the treatment plan system, and the needles are reconstructed, and the PTV and the OIRs are delineated in the TPS, and the planning is done. And we evaluate the plan properly based on the defined constraints and the coverage details. And if there is any issue, we always try to optimize it. We do the geometric optimization, we do it. And then the patient is taken for treatment. Patient is the needles are connected to the HDR machine. And we should also be very careful when we remove the implant, as following the policy, the principles that I already told. And most important, to ensure that the hemostasis is achieved before you send the patient to ward. Thank you.
Prostate brachytherapy, its cost, what is the gap between placement of pressure and spacer and procedure for prostate brachytherapy. And my another question is, sir, that you have nicely told us about this on-center prostate brachytherapy, which is definitely the contemporary standard of prostate brachytherapy. So in on-center brachytherapy, the patient is constantly in the lithotomy position. During the application, there is live image transferred, USG images transferred to the treatment planning system, and till the treatment, the patient is kept in lithotomy position. So you have 5 gray in 2 fractions. So why not 15 gray single fraction when it is a well accepted dose fractionation schedule in prostate brachytherapy as boost?
Yeah, regarding the OIR spacer, we do not use the OIR spacer. Definitely, it will be very advantageous, especially in brachytherapy, even for external beam also. You will be able to create a gap between the rectum and the prostate. Mainly, we are not using it because I don't have a personal expertise with the OIR spacer. And in fact, in between, we thought of starting an indigenous sort of approach by injecting, but we didn't. That project didn't pick up. So I don't have much experience. It's costly also. So, and the second question regarding the dose for on-center prostate, because I followed the dose schedules that were done in Sana Klinikum Offenbach in Germany. So that is why we are sticking to that protocol. As of now, we have data for 15 gray single fractions. I think that will be really welcome, so that you don't need to have two procedures for a patient. But since we are following the prescribed dose and we are comfortable with it, we didn't change.
Just one more question, sir.
No more question. Please, you can discuss afterwards. We are running out of time, so thank you, Dr. Haresh, for that nice video and nice presentation. Thank you.
So Dr. S.N. Senapati, to felicitate our speaker, Dr. Haresh KP. I request Professor Dr. Madhavananda Kar sir to felicitate our chairpersons, Professor S.N. Senapati, Professor Niharika Panda, and Professor Bhagya Lakshmi Naik.